Now we have the panel discussion from our eminent speakers and the clinicians from different parts of the country. So the panel discussion is about the clinical decision support tools and the way forward of how to improve the care in the ICUs. So for the panel discussion, we have three eminent speakers. The first speaker of the day is Dr. Sanjith. Dr. Sanjith is the HOD of the Department of Critical Care, Fortis SL Raheja Hospital, Mumbai. We have a fellowship of neurotrauma critical care at the Hadassah University Teaching Hospital at Israel. He has also completed the European diploma in the critical care from Brussels. His line of interest lies in neurotrauma critical care, mechanical ventilation, and nutrition in the critically ill patients. He's got about 75 peer-reviewed articles to his credit. He has written one book, contributed about 7 chapters to about 7 books. He has 7 Best Research Paper Awards and a gold medal, winning patented software in the field of critical care nutrition, Best Innovation Award for technology patient interface called the Vocalizer. He's an excellent orator and a teacher. He's an active faculty in a number of national and international conferences. He remains the organizing secretary of the very sought after annual mechanical ventilation workshop and the nutrition boot camp that is held in Mumbai year after year. Welcome, Dr. Sanjil. The second panelist for the day is Dr. Sudipta Mukherjee. He is the consultant critical care medicine, Tata Medical Center, Calcutta. He is an instructor of ACLS and basic life support under ACC and AHA, and a trainer of management of COVID-19 pneumonia. His interest spans over airway management, mechanical ventilation, advanced hemodynamic monitoring, and point of care ultrasound. He had presented a number of papers in Criticare and ISICEM Brussels. He has 13 peer-reviewed articles published and contributed chapters to about 3 books. Welcome, Dr. Sudipta. And the third panelist, Dr. Farhan, he is a pediatrician. He is a pediatric intensivist. He is the head of the Department of Pediatric Intensive Care Unit from Rainbow Hospital, Chennai. From Rainbow Children's Hospital, Hyderabad. He is the principal assessor of NABH and the past member of the technical committee of NABH. His area of interest are application of mechanical power and lung protective ventilation in pediatric population, the extracorporeal therapies in pediatric patients like CRRT, cytosol, ECMO, and also his interest in quality and patient safety in healthcare industry. We have multiple publications in several peer-reviewed pediatric journals and is working on novel areas of pediatric lung protection. So welcome all panelists. Thank you for being here, sir. And we welcome you on board for this launch event, as well as for an exciting discussion on the clinical decision support tool and the trends, what's happening in the ventilator science. So let me first ask Dr. Sudipta. So we are talking about the protective strategies, lung ventilation, lung protective strategies, protective ventilation strategies. What does it mean to you in your clinical practice in your hospital, sir?
Good evening, Dr. Prabhu, and good evening all the panelists and eminent person present in this program. And thank you for inviting me to this podium and allowing me to share my practice with everybody. So when we are talking about protective ventilation, the concept has been imbibed or taken from a standard medical profession which says that do no harm. So it is also applicable that whenever we are doing a ventilatory strategy, setting our ventilatory strategy, we should state it judiciously so that it doesn't cause any injury to the lung. From 2001, we understand that the initial concept was to ventilate with a low tidal volume, and studies have shown that even with a higher tidal volume give better oxygenation, the final outcome is poor. So we understand that everything which is more may not be good for the patient. Along with the low tidal volume, we all know that about the optimal setting of the PEEP, which not only help in better oxygenation, but also prevents for tidal recruitment during the tidal ventilation and at electrotrauma. This, unless it is prevented, it will also cause lung injury and worsening of the lung function. We need to optimize our respiratory rate so that we can achieve our optimal minute ventilation. Along with that, we know about the other pressure cutoffs like plateau pressure, which usually standard is 30, In recent studies that share about the importance of driving pressure, we understand we keep it low and preferably below 16 centimeter of water so that the damage of the lung can be reduced. Also, we understand the importance of transalveolar pressure. And all these things contribute to the stress to the lung. So whenever we are setting a ventilatory strategy, we should keep all these parameters in our mind. Along with this, recently we have understand about the strain to the lung, which caused because of the functional residual capacity. So by that, we need to avoid hyperinflation and also at the same time have to prevent or minimize collapse to prevent damage to the lung. And all these things eventually coming to only one word, that is mechanical power that is transferred to the lung from the ventilator. Our target should be to decrease the mechanical power so that a cumulative lung injury will be less whenever we are ventilating patients for a longer duration.
Dr. Prabhu, please unmute yourself.
Yeah, thank you, Dr. Sudipta. Now I flip this question to Dr. Sanjith. Dr. Sanjith, we are again talking about the lung protection, but by and large, the belief is that the lung protective modes are sufficient to take care of the lung ventilation. Do you think that we are missing some vital clues that we should be looking for or we should be aware of to deliver the optimal care when we talk about the lung protection?
Yeah, so good evening to one and all. So it's very broad to actually say that a certain number should be adequate for a certain group of patients or for the entire population, like a plateau pressure of less than 30 is enough, or a certain driving pressure is enough. It's extremely difficult to actually come to that sweet spot. In fact, the answer to the question would be to actually personalize the care much better, personalize the ventilation much better to understand. A 7 ml or a 6 ml per kilogram tidal volume could also be dangerous if by any chance the tidal volume is going into a relative volume that is much smaller. So that is another problem that comes in. So if you have the FRC to be low, you ventilate a larger volume in that smaller FRC, the chances are that you will probably make higher stress. So strain, that is, so on an average, I don't think we can take a certain number, and it is important to personalize ventilation, and that's why we're missing all these numbers if we do conventional modes of ventilation, is what I feel.
Right, what he says, sir. So, Dr. Farhan, now I turn this question over to you, sir. What are the protective strategies applied to the pediatric patients? Are they any different from the adult needs, or what is your take on that?
Yes, as Dr. Sanjith rightly said, this number game is very dicey, and particularly it holds true for pediatrics because most of the ventilatory strategies which we use in pediatric age group are derived from adults, and children are not small adults. And the problem is the numbers which adults have given are not directly applicable in pediatric ventilation. So the PALIC, the Pediatric Acute Lung Injury Consensus Conference, which was published in 2015, gave some, again, certain numbers like the peak inspiratory pressure, because most of the children are ventilated in pressure control or PRVC mode. They are not ventilated in volume control mode. That's a big difference in adult and pediatric ventilation, first of all. So we don't have a PEEP plateau most of the time. So we have PIP, peak inspiratory pressure, and we target it at 28. And we adjust our volumes to 3 to 5 or 3 to 6 ml per kg so that our PIPs are below 28 centimeters of water. And then we maintain our inspiratory time, respiratory rate. Again, as the child increases in age, the respiratory rate will go on reducing, airway resistance goes on reducing in children. So children are very unique. As the child grows, these parameters also keep changing, and we need to adjust our eye time based upon that. Then the PEEP titration in as the ArtsNet had given a FiO2 to a PEEP chart, but in pediatric you can't use that because you will inadvertently use very high PEEPs if you use that chart. So we use PV loop for PEEP titration. We use bedside ultrasounds also for PEEP titration, and now with GE CareScape R860 VA version 11, you can actually measure a bedside FRC, and that I'm very excited to use that module because that will really help us to measure FRC and more accurately titrate PEEP at the bedside, and that will be very useful for pediatric ventilation. Then in moderate to severe ARDS, we have proning, and we are still using HFOV. In adult ventilation, they have abandoned HFOV, as I know from my adult colleagues. But in pediatric age group, we still use, right now in my ICU, 2 children are there on high frequency oscillation. So we still use HFOV for our children. Esophageal monitoring is not very much in vogue in pediatric age group, mainly because the size of the esophageal catheters are not available and they're very costly. But older children, we can use them. Then the concept of driving pressure. The pediatric acute lung injury consensus conference was published in 2015, and AMATO also published in 2015 the paper on driving pressure and its association with ventilator-induced lung injury. That's why PALIC guideline do not mention anything about driving pressure. But one thing which is interesting in AMATO's paper is he mentioned that driving pressure should be less than 15, but he also mentioned that the P plateau also should be less than 30. And when your driving pressure is less than 15 along with P plateau less than 30, then it reduces mortality much better than other combinations. So then again, it is highlighting the same thing which the PALIC says, that the PIP should be less than 28. So these are the things. Apart from that, P-SILI, particularly during this COVID pandemic, we have seen. So we need to be very careful about spontaneous breathing of the children, and esophageal monitoring, pressure monitoring will be able to find out the spontaneous efforts from the children, and use of adequate PEEP to prevent P-SILI is important. Diaphragmatic protection is also very important. So newer strategies to protect the diaphragm, nutrition, particularly airway occlusion pressure can be used to find out the negative pressure drop and assess any movement of the diaphragm, and prevent P-SILI and diaphragmatic atrophy or overuse of the diaphragm. And finally, patient ventilator asynchrony. Again, a pediatric ventilation, that's a big problem. So we need to use our pressure and flow triggering more smartly. And of course, NAVA is there. So NAVA mode is also very, very useful mode for a better patient ventilator asynchrony.
Thank you, sir. So you have brought up the point of FRC and the transpulmonary pressure measurement and other ways of assessing the stress and strain relation to the lung protective strategies. So now, Dr. Sanjith, you have been using these tools like FRC and esophageal pressure monitoring for about at least 4 or 5 years now. And we hope that it has provided greater insight about the lung mechanics and informed decision making and clinical judgment. What would you like to share your experience with our audience, how it changed the outcome and practice? What level of expertise do you think, sir, we need to use such a kind of tools?
All right. So it is now also secretive to understand what should be the right pressures in the lung. And frankly speaking, there are absolutely no secrets in life. It's just hidden truths that lie actually beneath the surface. And to understand what's beneath the surface, you need to actually see what's beneath the surface. So, let me just show you some data that I have, which I hope you can see the data. I hope you can see my slide.
Yeah, you can see your screen.
All right. Right. So the question is, how to catch the sweet spot? That's the big question that we have to answer here. What is the right tidal volume? What is the right pressure that you have to give? And how do we avoid going beyond or lesser than what we have? Because going more is harmful and going less is harmful. That is the biggest thing that we do in ventilation. So let me show you some data that I have from COVID after my experience of using electrical impedance tomography, transpulmonary pressure, and expiratory lung volume. Yeah. Okay. Slideshow. How do I do that? Stop share. All right. So the question that we have over here is, how do we catch the sweet spot, the right spot as to how to ventilate your patient with respect to not more, not less, like how in the hemodynamics we say we should not give a single drop more fluid or a lesser fluid. How to catch that sweet spot is a big question, or the right way to ventilate. And let me show you some data that I got from COVID on this after my use of electrical impedance tomography, transpulmonary pressure, and end expiratory lung volume. So this is a data of around 30 odd patients who underwent recruitment via staircase maneuver. All these patients have been admitted into the ICU and all have been severely ill, such that they all required mechanical ventilation. So this is the characteristics of those patients. If you look carefully, it is the severe category of patients that we had over here, with Apache scores hovering around 20 and with SOFA scores also on the severe range. Around 27 odd patients were there in this particular group of patients that we had. Now, what we found out from the use of actually end expiratory lung volume and electrical impedance tomography was the fact that almost 66.7% of these patients were actually recruitable. I mean, this is completely different from what COVID literature has showed us. COVID literature showed us that around 27-28% of the patients are kind of recruitable, at best 35%, but we've got 66.7% that was recruitable. And if you look at the graph there, it clearly shows that even after 2 hours to 4 hours also, we maintain their saturation. This was the result of our study. In fact, what we found out at the end of recruitment was the fact that the plateau pressures came down. Now, how did we manage to do this? We managed to do this because we understood the volume that was gained after the recruitment. And this is the volume that we gained in recruitment. And what we found out was those patients who were recruitable gained a larger volume. How are we going to understand this unless we measure that volume? And the only way we can measure their volume is by actually understanding end expiratory lung volume. So look at that. That's the volume that gained. And that was those patients that were kind of recruitable, is what it looked like. Most importantly, those patients who gained volumes were actually those patients who survived. That means if you gain more volume, you recruit better and you survive better, is what it looks like in COVID per se. Now let's look at another small data that we have. This is another patient, obese male, age 74 years old, who basically, this were his findings. On PEEP, we actually went from 12 to 14 to 16 to 18. We calculated his FRC by end expiratory lung volume, and we found it to go from 1,200 to 1,942. A good jump on the FRC, a good gain of volume is what we found. We also found the compliance to actually come down, however. It came from 31 to 24. So where did we go wrong here? In fact, the plateau pressures also started going up. And look at the saturation, it didn't change at all. So we did go from 12 to 20. We found the FRC to go up. However, we didn't find the saturation to change at all. So what happened over here? We found PEEP going up. We found the FRC going up. This is calculated very clearly by end expiratory lung volume. However, the compliance went down, the plateau pressures went up, and the saturations really did not improve. So what did we do? We gave these positions, we gave these patients left lateral, right lateral, left lateral, right lateral, and we measured electrical impedance tomography. The FRC remained the same. But what is important for you to understand is that we were able to move air in those areas that were not ventilated. So this is the importance of using a coupled electrical impedance tomography along with FRC. Now look at this. This was before right lateral, and this view is 4, 34. This is the quadrants: 4, 34%, 57%, and 6. This is what it looked like from top to bottom. Now we gave him the right lateral position, and the same patient showed it going from 4 to 10, 34 to 48, 57 to 36, and 6. This means there has been a redistribution onto the ventral area of this particular patient. Look at this. Before left lateral again, you had 9, 37, 46, and 7. And what happened after left lateral? You now see it going to 17, 42, 29, 12. What have we avoided? We have actually avoided prone ventilation completely by just a great scientific jugglery between EIT, functional residual capacity, and monitoring of transpulmonary pressure, because we know how high to go and how low to go here. So that's what this particular technology does help us to do. It gains us objectivity in care rather than just looking at a saturation that we normally otherwise would do. So lateral position, if prone position is not possible, is probably what we gained from the data that we had from our study. So I think without using objectivity in care, looking forward, I don't think ventilation can be done protectively. And that is the reason that I would recommend each and every person to have esophageal manometry to gauge your transpulmonary pressure, to know the limits of recruitment, and at the same time an end expiratory lung volume to understand what is happening when you're actually giving that high pressures. And at the same time, you also need an electrical impedance tomography to ensure, apart from compliance, that you are not distending the zones that are already distended. In fact, you're opening those zones that were previously collapsed and thus recruited. So it's a beautiful way to do ventilation is what I feel.
Thank you, Dr. Sanjith. That was a wonderful insight about using different technologies to come up with the optimal results which we can deliver to the patient here. Thank you very much for that insightful data, what you had shared with us. Dr. Farhan, you have been working on a novel concept like mechanical power in pediatric patient population to identify the lung stress.
Yes.
The next speaker, Dr. Gattinoni, is an expert in that thing. So you have been already using this in the pediatric population. Would you please share your experience with the audience of your novel technology methodology and its
I'll start.
What were the observations from the data?
Yes. I'll share my screen. So this was our analysis of mechanical power in pediatric patients at Rainbow Children's Hospital, Banjara Hills, Hyderabad. We know this famous equation which was proposed by Dr. Gattinoni in 2016 to calculate mechanical power, which is the energy measured in joules per minute. We know driving pressure, which was proposed by Amato, but the problem with driving pressure is it is talking only about pressure variables. And the advantage of mechanical power equation is this mathematical description is giving you quantification of different components. Apart from pressure variables, other variables like tidal volume, respiratory rate, inspiratory, expiratory, IE ratios, flow, etc., airway resistance. And then you can individually anticipate the effect of their changes. Next year, Girin did an analysis of 787 ARDS patients from 2 RCTs and gave us the cutoff values also. So driving pressure's cutoff value of 15 centimeter, which was already given by Amato, was further confirmed by Girin in this study, and mechanical power's threshold was given as 12 joules per minute. So anything more than that was considered to be harmful. So when we look at this equation once again, this particular volume is a problem in our practice. This is the end expiratory lung volume, which is the volume displaced or given by application of positive end expiratory pressure. But with the present GE-Carescape R860 version 11 ventilator, measurement of this particular volume is possible. There are some unique challenges in children. Dr. Gattinoni's equation was validated in volume control mode. And as I mentioned earlier, children are ventilated in pressure control mode mostly, and recently many people are even using PRVC mode. But use of volume control mode is very less. Secondly, as the age increases in children, the airway resistance goes on reducing, and the respiratory rate also starts reducing in children. And as the age increases, the tidal volume increases in children. And to take care of the rising tidal volume with age, we can divide mechanical power with the calculated weight, body weight, and calculate normalized mechanical power, also called as NOR-MP, that is MP per kg. So we can take care of tidal volume by taking MP per kg, but still we cannot take care of the falling airway resistance and falling respiratory rate, which happens as the child increases in age. So this was the equation proposed by Tobias Becker in the subsequent year. I think in 2018, this equation came. This was the mechanical power equation for those who don't want to measure end expiratory lung volume or in pressure control mode. So in our analysis of 299 patients, what we did is we calculated mechanical power using Becker's equation from 1 month of age to 15 years of age at 2 different tidal volumes of 4 and 6 ml per kg. We had children with normal lungs, children with pulmonary edema. The pulmonary edema could be because of cardiogenic pulmonary edema or ARDS, and children with increased airway resistance. And we found that the mechanical power at 4 ml per kg for normal lungs was 1.058 joules per minute, while it was at 6 ml per kg around 1.834 joules per minute. So this is significantly less than the adults' mechanical power, which were around 8 to 10 joules per minute. So and this could be because the tidal volume used in pediatric population is very small compared to what adults are using. Now coming to the edematous lung, we have seen that at 6 ml per kg, the mechanical power was roughly 3.29 median with the range of 1.7 to 6.11 joules per minute. And in resistive lungs, with airway resistance, there was not much change in the mechanical power at 4 ml per kg as well as 6 ml per kg. Once again, signifying that airway resistance is not allowing the mechanical power actually to reach the alveoli. Now, this is an interesting table. This table talks about the relationship of age. And as we can see here, as the age is increasing, the mechanical power as well as the normalized mechanical power, that is mechanical power per kg for both 4 and 6 ml per kg is per kg of tidal volume is going on increasing, as we can see here. And one interesting thing is when the tidal volume changes from 4 to 6 ml per kg, there is a significant change or rise in the mechanical power as well as normalized mechanical power. Now, as we see here at 4 ml per kg of tidal volume, we can see the mechanical power is rising, particularly after the age of 3 years. But when we see normalized mechanical power, that is mechanical power per kg, we don't see much change up to age of 10 years. And then after age of 10 years, actually we see a little dip in normalized mechanical power. And what we thought is, actually I would like to know this from Professor Gattinoni also. What we thought is this absolute mechanical power, which is increasing after 3 years of age, is because the tidal volume is increasing as the age increases. And in normalized mechanical power, we are dividing by weight. So we are actually cancelling the impact of tidal volume, but the airway resistance is falling and the respiratory rate is falling as the age increases, which is particularly prominent after 8-9 years of age. So we can see here the normalized mechanical power falling a little bit as the age increases, particularly beyond 10 years of age. The same thing which we see at 6 ml per kg also, absolute mechanical power rising with age and normalized mechanical power remaining static till 6 to 8 years of age group. And then after 10 years, there is a slight dip. I think this is because the airway resistance and respiratory rates, which are falling as the child increases in age. And this was the correlation analysis which we did for age. The negative correlation means as the age increases, this particular factor is falling, and the positive means it is rising. So when the age is increasing, the respiratory rate decreases, the airway resistance decreased in our data, the tidal volume increased in our data, mechanical power increased, and normalized mechanical power decreased. So once again, as we can see here, mechanical power increased with age, normalized mechanical power decreased with age. Now, we also did a retrospective analysis on 185 patients of pediatric ARDS patients between 2017 to 2020. And we found that median mechanical power was around 3.95 to 3.99 joules per minute. And we found that the correlation coefficient with oxygenation index was best with driving pressure, followed by normalized mechanical power, and least with absolute mechanical power. While 28 days ventilation free days had negative correlation with driving pressure, and then next with normalized mechanical power, and there was no correlation with the mechanical power. And we saw that P SOFA at 24 hours, that is pediatric SOFA, and driving pressure at 24 hours independently predicted mortality. And driving pressure more than 13 at 24 hours had 80.2% sensitivity and 65.4% specificity to be associated with 28 days mortality. So the cutoff value which was given by AMAT of 15 centimeters of water was not getting applied in our cohort. So in our cohort, we found 13 centimeters of water of driving pressure was actually was associated with the increased mortality. So what we found was NOR-MP or mechanical power per kg was correlating better with outcomes like oxygen index, 28 days mortality compared to absolute MP. And what important thing is, we cannot simply borrow the concept of mechanical power from adult studies and apply in pediatric population. And we need to address the effect of respiratory rate, airway resistance, and tidal volume with age before we actually apply truly these concepts in children. Thank you.
Thank you, Dr. Farhan, for giving this wonderful insight about the novel way of looking at things, which is really helping the pediatric age group patient and how it is different from the adult patient category. It was really insightful. Now, let me flip the question to Dr. Sudipta. So you are coming from the oncology specialty hospital, the Tata Medical Center from Calcutta. What are the special applications or tools you use in your patient care at Tata Medical Center for safe lung ventilation strategies or palliative care?
So, Dr. Prabhu, that for palliative patients, mostly what we do, we try to avoid the intubation. So we try to keep them either on HFNC or an NIV, and unless we are sure about the long-term outcome of those patients. But when you talk about ventilating the cancer patients, sometimes it is very, very challenging because they have different associated aspects, like some patients may have a prolonged neutropenia and requiring ventilation for a very long duration. Some may have a surgery with an surgical site complication. So in the background of ARDS, you cannot make them prone. So it is more important for us to understand the lung physiology very well. I agree with my previous two speakers that it is the era of personalized care, and whenever we are setting the ventilator, it's also important to streamline or optimize it as per our patient's requirement. But we also need these numbers because we need to start from certain point, right? And also it is very important for our other colleagues to be in the same page so that they can initiate their ventilatory strategy to prevent the lung injury as low as possible. So whenever we are setting the ventilator, we mostly start with a single number of 6 ml per kg. Then we try to set up the PEEP, and mostly we do that by a decremental PEEP approach. When we do that, we gradually increase the PEEP to a higher value and then decrease it and try to get the best possible PEEP with the best possible compliance for our patients. And after that, once we get a certain rate, then we try to use the PEEP module. And with that, I get an optimal PEEP, which can guide us in terms of best possible FRC and best compliance for my patient. Before that, we try to incorporate the PEEP. Again, after that, if there is a higher pressure or higher diving pressure is going, probably try to cut down the tidal volume further and sometimes go as low as 4 ml per kg. So with this help of the PEEP module and the FRC module, we try to optimize the stress and strain to our lung. And after that, we need to change this on a case-to-case basis and try to keep a balance between the FiO2, oxygenation, pressure, and volume. With this, we also using spirodynamics module and we look at the compliance of the lung during different phase of inspiration. And if we find that with the progress of the inspiration, gradually the compliance is improving, that means there is a tidal recruitment and lungs alveolus are getting opened up within the process of inspiration, and obviously which will cause more lung injury to the lung. And again, we try to set our ventilator so that the compliance stays reasonably constant during all phases of inspiration. We also use esophageal pressure measurement in case-to-case basis, specifically in patients with abdominal surgery and who will not are not the ideal candidate for prone ventilation. So with that, we try to get the pleural pressure, because with an abdominal hypertension, pleural pressure will be positive and sometimes it is significantly high. And with this information, we try to optimize our transalveolar pressure so that we can ventilate them with a minimum damage to the lung.
Thank you, Dr. Sudipta. Thank you for giving that overview of how the palliative care you are managing in the hospital, as well as using the protective strategy. Now, if I have to shift the gear, Dr. Sanjith, I'm coming back to you again. Would you like to share your experience on the indirect calorimetry, which is used for the nutrition assessment, slightly away from the lung protective strategies? So has it changed your approach after you started using the indirect calorimetry in your website? Are the data available with you? Do you think is it appropriate for Indian population to use the data which is available with us, probably from the Western world?
Right. So this is something that is quite close to my heart. The course of energy expenditure is very, very complex in critical care. I mean, there may be an F phase, there may be a flow phase. We don't know at what point our patients are at with their energy levels, and we think that there is an increased catabolic state at the start and probably a energy sufficient state, which later on becomes energy insufficient. So if we are going through so many phases, how is it possible to have a single equation to actually calculate your energy requirements? It's just impossible to do that. And that is the reason that in the era of personalized medicine, we actually should understand energy expenditure via indirect calorimetry. Yes, it has changed practice quite a bit, because I used to believe that predictive equations were the way to go, 30 kilocalorie per kilogram. And especially in the COVID era, they said 30 kilocalorie to 35 kilocalorie. You'll be astonished to figure out that the data from the Indian subcontinent, at least from my unit, says not more than 15 kilocalorie per kilogram is the requirement for a long period of time in COVID. In fact, it's not 30 to 35, it's around 15 to 20. How can we know this? Only and only when we monitor. How is it possible to titrate a vasopressor without actually monitoring the blood pressure? Similarly, how is it possible to feed somebody without actually measuring what he needs to be given? So the only way you can do that is by indirect calorimetry. And it has completely changed. Yes, the Indian scenario has a lack of data. It comes from sparsely from a few centers that actually monitor indirect calorimetry. But what we know has changed the way we practice. We've started measuring what we need to provide, and that's changed the way we ventilate our patients. Patients have got weaned off faster. We've got data that talks about decreased length of stay in the ICU as well as length on the mechanical ventilator. It has also helped us to make new diets for these kind of patients.
Thank you very much, Dr. Sanjith, for that insightful thing. So the input data which goes into measuring the energy expenditure of the indirect calorimetry is the VO2 and VCO2. Do you also see that these data are having other implications?
Oh yes. So it's very exciting to see for that question is very exciting to me, because sometimes it so happens that the respiratory quotient is on the above ranges at 0.6 and 0.65, and sometimes the respiratory quotient is at 1.2, 1.3. At that time, you must understand that probably the fuel used for energy expenditure is fat at one side and carbohydrate on the other side. This might at times lead to the patient not being able to wean off the ventilator. That's one part of the respiratory quotient that we could use. The second part is the VCO2. See, the VCO2 is not equal to the ETCO2. It's very different. The ETCO2 would change with respect to alveolar ventilation, but it's the VCO2 that changes when the carbon dioxide production changes in the metabolism in the tissue. So we'd probably be able to pick up, say, non-convulsive status epilepticus, maybe a hypermetabolic state by just looking at VCO2, because the VCO2 would just climb up. But the alveolar ventilation being regular, maintained at the same level, would not really change the ETCO2 quickly. That's why the VCO2 application would be great in the domain of mechanical ventilation.
Yeah, thank you, Dr. Sanjith, for sharing your experience with the audience. So the one last question to Dr. Farhan. So where do you see the future trend of pediatric ventilation? If you can briefly say in 30 seconds, if you have to summarize it, what would you think?
See, the future, a lot of things are there, as we are already discussing: patient safety, lung protection, diaphragm protection, patient ventilator asynchrony, minimizing all these things. There are some interesting concepts like introducing driving pressure as one target in proportional assist mode of ventilation. It will be very nice if we have proportional assist mode in all ventilators. Then, of course, now with the CareScape, this new mode which can measure the end expiratory lung volume, indirect calorimetry, these are so exciting. And I think this is the future. This is the place where the future lies. And apart from that, we will all progress to these things, I'm sure. But one thing which hit us hard during this COVID was non-availability of ventilators. And I think the companies should think about that also, because so many people suffered because of non-availability of ventilators in particularly the second wave in India. So how we can devise ventilators in future which are easily available, which do not depend on central oxygen and air, compressed air, and which easily available, and where we can, or even possibly, we saw the videos on WhatsApp, one ventilator being used for 3 patients, 5 patients. So is it actually possible, and can we actually do it? And is it feasible in a mass basis, on a massive basis? Can we something outrageously think something like that, something wild, something like this?
All right. Thank you, Dr. Farhan. And we thank all the 3 panelists who have been sharing their experience as well as sharing their knowledge with the audience, especially in the topic like lung protection and the weaning or indirect calorimetry. It was a pleasure to have you all 3 panelists and eminent from different parts of the country. Now we are at the end of this thing, and I request the audience to post your question in the chat window if you have anything to ask for the panelists. Because of lack of time, probably we may not take it now, but we will get back to you as an emailer back to you.